Okay, so there will be 4 interesting parts of the agenda. We've done with the first one, actually, because it was the opening remarks and welcoming addresses. And now we're going to have the first 2 panels in the morning, the proclamation of the Ottawa Declaration, and the 3 panels in the afternoon. So before the first break, we're going to move to the first panel. Et comme vous le savez, nous allons faire revenir le dernier orateur sur le podium, si je me fie au programme que nous avons. C'est exact. Je vais lui remettre la parole cette fois-ci pour qu'on parle des déterminants sociaux de la santé et de la santé mentale des communautés noires au Canada. Donc, avec votre permission, Dr. Awad Ibrahim, vous voulez bien revenir ici, s'il vous plaît, pour le tout premier panel. Je pense que ça va se passer avec nos 2 principaux intervenants que vous allez certainement introduire tout à l'heure. S'il vous plaît, est-ce qu'on peut l'applaudir à nouveau puisqu'il revient?
My apologies, OmiSoore. I know I received the bio in my email, but I don't have it open, so my apologies. I know OmiSoore from Dalhousie. She's actually one of our strong poets, if you like, and she had done incredible work around this question, from mental health to physical health of Black people. She had done tremendous work and research in the area of the social determinants of health. So she will take the floor. So please come in.
Good morning, everyone. How are you? I should use the mic so I can see. Oh, yes, I will. Thank you. Oh, my gosh. So many mics, so many things. Give me a moment. Good morning. My name is Dr. OmiSoore Dryden. I am a full professor at Dalhousie University and a recent Tier 1 Canada Research Chair in Black Health Studies. Thank you. So I am from Ontario, though not born in Canada, but I currently live in Halifax, amongst the Mi'kmaq, but most importantly, amongst African Nova Scotian communities. And my gentle correction would be that African Nova Scotian communities, in addition to being the oldest communities in Canada, are actually closer to 9 or 10 generations here in this space that we call Canada. They are Afro-Indigenous, they are Indigenous Black people. They carry so many of our histories with them because of their historical positioning in this space that we call Canada. So I just want us to make sure that we understand the richness and the gifts that they have brought, that they bring to us through their historical positioning here. So if you're from Ontario, you're familiar with historical Black communities in southwestern Ontario, close to London, where I was raised, Chatham, Don. And if you're from British Columbia, you might be familiar with historical Black communities on Salt Springs or Hogan Alley. But we have always been here. Even that brief moment when I lived in Sudbury, I realized that there was a historical Black community from the 1888s, right? And I want us to remember that Black people are not settlers. Many of the treaties signed in this country were signed before the end of slavery. And if Black people were spoken about, we were spoken as goods to be traded. So we need to remember and be really thoughtful about how we speak about our relationships with Indigenous peoples here through our historical indigeneity as people who were stolen from our lands, moved from our lands, pushed out of our lands due to climate crisis, environmental conditions. And today is also the Trans Day of Remembrance. And I want to make sure if we're talking about Black health, that we're talking about all Black people, all African Nova Scotian people. And that includes 2S LGBTQI folks. I'm a Black queer femme. I've done this work for forever. And if you know my work, you know that I insist on including all Black people. So in your research, make sure you're also speaking about Black 2S LGBTQ folks. And I hope we're named in this declaration today. There was a 2S LGBTQ study in health produced by the federal government in 2019. And not once will you see the word Black or Black people in that report. And that's because of systemic anti-Black racism in predominantly white, queer, and trans communities in this country. But we believe in Black excellence, and Black excellence must also include Black 2S LGBTQ people. I don't know how this works. Oh, thank you. I want to thank my brother, Jude Sinha. We've been in some things together. We've been in these trenches. I want to thank my sister, Biba. I see you, girl. I see what you've been doing. I'm going to be talking about the social and structural determinants of health. I teach in the Faculty of Medicine at Dalhousie, and I say to the Med 2 and Med 1 students, when they're like, what does slavery and racism have to do with medicine? I was like, everything. The first medical school in Canada opened in 1824. Slavery didn't end until 1834. Medical education began in this country before we were considered people, and in many ways we still aren't considered people. Hat tip, scientific racism, race biology. We see the ways in which these things continue to impact us. So when we think about, my apologies, my back's going to be to you. When we think about what health and social and structural determinants of health, thank you for doing the edits. I don't even know how long you stayed up last night, but we thank you for everyone pulling this together. We need to think through how our society, how socially and structurally we are impacted in our health. Hi, Lloydie. I share this data with my med students when I say 50% of what makes people sick is their environment. Do you have housing? Do you have education? Do you live in a food desert? Are you overhoused? Are you underhoused? 50% of what makes people sick are the social and structural determinants of health. 25% is whether or not you have access to care. Do you have a physician? Was your emergency room closed last night? Do you have a nurse practitioner? How long is the wait to get in to see your nurse practitioner? So 75% of what makes us sick has absolutely nothing to do, did not generate, did not start in the body. It started through how we live in the world, and that includes the physiological impacts of racism. You just got into it at work because somebody can't stand your brilliance, and then you feel worn down, your body starts to hurt, you start to cough, you have a headache. Physiological impact of racism. That happens repeatedly, fibromyalgia. That happens repeatedly, right? It kicks into gear that chronic illness, that autoimmune disease, that takes forever to be diagnosed, right? These are the things we're talking about. Systemic anti-Black racism, and we need to say that specifically, is this thing that undergirds how we understand health and wellness. And in the work that I do, I look also at systemic anti-Black homophobia and transphobia. Yeah? Where am I pointing? There we go. So, economic inequalities, I saw this multiple choice question for an upcoming exam, and the question was, what is the leading social determinant of health that causes illness? And it pulled out poverty, pulled out income. And this is how you know people creating this question don't understand how intersectionality works. Because in Black communities, we can't pull out poverty from the conditions of Blackness. We can't pull out lack of education or barriers to education from the condition of anti-Blackness. We can't pull out these things. When we look intersectionally, we need to understand that poverty in Black communities is rooted in what? Systemic anti-Blackness. That is a structural thing. The thing that prevents you from moving to different neighborhoods. The thing that prevents you from living in a place that has fresh fruits and vegetables. Political and scientific underrepresentation. Where are our methods? Why are we not using critical race theory, Black queer analytics, Black feminist health science? These are real things. They're not just words that we smush together. These are the things that Black scholars have been pulling together to apply to the very rich research that we are doing. So yes, we need to be at the table, our voices need to be heard, but our research, our methods, our analytics, these are the things that are going to be innovative in the research that we do, right? This is the message that we need to continue to bring. So to better understand, we need to realize the persistence of the barriers, the geographic inequalities. And living in Toronto and Ontario, and then moving to Halifax in Nova Scotia, you really do see the disparities amongst the provinces, right? I don't understand why I can't get ripe plantain in Nova Scotia. I don't understand that when I come, I have to put it in my suitcase and say, please don't take this out of my suitcase. I just can't get it to ripen in Nova Scotia, right? I can't get callaloo. Anyway, I'm going on. Challenging structural injustices. We know what that labor is like. It leaches from our marrow. But we know we do it because we must insist on better health for ourselves, our children, our elders, our communities. And the role of culture, whether it's the mosque, whether it's the spiritual space, whether it's the truth, the church, whether it's the community center, the queer community center, the drag ball, the place where you go and you find chosen family, community family, whether it's the barbershop, whether it's the hairdressing or the loctician, that might be the place where someone says to you, you've had that issue for a while. You really need to try and go back to the doctor. I'll come with you. Let's make sure we can go together. That's the one that's like, no, it's not supposed to look like that. You need to go and get that checked out. These are the roles of culture in terms of how we have facilitated with each other, how we're going to make sure we get care. This data is so important. It becomes meaningless if we can't apply it, if we can't make sure they're taking it and using it and looking at the structural pieces to disrupt that. And if there's decision makers in the room, let me just say, that might mean having to take somebody out of their role and pulling somebody else in their role so they become a facilitator of the process and not a gatekeeper to stop it from moving. That might be what the decision is. The healthcare system continues to really not see the impact of systemic anti-Blackness in health. Everybody saw that TikTok out of the US where that Black woman was just trying to be in pain, and then that white woman was like, we got time, and then 12 minutes later, she had her child. And then you saw the other one where they're like, oh, it ain't time, you have to leave, and then her husband delivered the baby in the car. We all saw what happened to Serena, right? Those things get in the world. We talk to each other. We say, girl, no, don't go there, or let me come with you. Oh no, you have to go to that blood draw place? I'm gonna come with you to that blood draw. Don't go there by yourself. These are the ways we navigate because the system has such a struggle, not only in recognizing the systemic anti-Blackness, but being able to make the change to disrupt that. So what do we need? We do need a recognition specifically of anti-Black racism. Now, you've heard me say that a lot. Why? Because it gets lost when we talk about systemic racism. We need to pull it out. If we are truly committed to a decolonial process, we need to continue to name the coloniality of anti-Black racism. Implementing anti-racist policies and practices and protocols strengthening anti-racist cultural competencies, anti-racist cultural safety, yeah? Black-led research, sometimes the reason why research takes so long is because I insist on all Black teams. So no, I'm sorry CIHR, it won't be done in 2 years. It might take that time just to get the team together, to get the community on side, all right? Collect race-based data ethically, and by that I mean data governance, data sovereignty. We get to decide how our data is going to be used. Yes, it will be used, but we determine whether or not that data will be further pathologizing us. Oh no, that just happens to them because of they the Blacks, right? Or liberating us. No, that's a social and structural determinant of health. We need to change that because these Black people deserve better care and outcomes. Promote social justice and make sure that we build social and structural policy. I'm right now. Look, we done. Right there, you see how that happened? Right now. I saw you coming, I'm right now. That's why I was running with the mic. For researchers, if you're a white researcher, don't reach out to us because you're trying to dip into the Black pool, and that's the only time you spoke to us. And when there's only one Black pool for the 15 Black researchers in the room, give us 15 Black pools. Decision makers, speak to us about every access, every part of the system, because every part of the system is the thing that needs to be restructured. And for practitioners, how do we do this in a way that understands not only our humanity, but our soul, the fact that we do have a future. We do have a thing to continue to grow and develop and be. Yes? And remember that also includes, what did I say? Black 2S LGBTQIA folks. Black, queer, and trans folks. And most specifically, African Nova Scotian folks. Thank you very much.
Now you know why she's well known nationally and internationally for her contribution on the Black studies in medicine, medical education, health research, and healthcare system. Thank you, OmiSoore, one more time. Now we're moving to the next speaker, Linda Iwenofu. She's an assistant professor in the Department of Applied Psychology and Human Development at the Ontario Institute for Studies in Education. Her scholarship focuses on understanding the ways in which individual differences such as race, ethnicity, poverty, immigration, and exposure to adverse events impact child and youth trajectories toward health and wellness. The floor is yours.
Thank you so much for that. And I'm Dr. Iwenofu. I know on the program it says Dr. Jusana. I'm not him, obviously, but he's given me the privilege of presenting on this topic with you all. So thank you so much for this space, and I'm really, truly humbled. And to follow Dr. Dryden, people that I admire is just wonderful. I am, as it was introduced lovely, I'm a professor at the University of Toronto, OISE. And I also do research on Black mental health, particularly with young children. So it's an honor to help open the panel on Black mental health as part of this gathering here today. I want to underscore what this topic is. You guys can hear me all okay? Yeah? Okay. So we're not just talking about mental health in general, right? With a few comments on diversity tacked on, but we're talking specifically about mental health of Black communities in Canada because race and racism fundamentally shapes exposure to risk and access to support and pathways to care, as many of us know. Black communities experience structural inequities that directly affect psychological well-being. So it's not just about individual coping or resilience, it's deeply shaped by these social and racial determinants that Dr. Dryden wonderfully presented to us. Despite significant needs, research and policy efforts are still quite limited. We still lack the level of investment, infrastructure, and race-based data collection that would allow us to design and evaluate effective, equity-focused mental health systems. So the central question I want us to think about as we move through is, how can we transform these conditions that shape the mental health of Black people in Canada, rather than just asking Black people to adapt, and cope with these harmful conditions that we often experience. So why do we need to, right. Why do we name Black mental health explicitly? Because we experience these structural inequalities at every level, income, unemployment, justice system, and healthcare, of course, all due to systemic racism. Our policies around immigration, labor, policing, education, healthcare, they all accumulate in people's bodies and in their minds. So if we ignore race and racism, then we're ignoring a central driver to mental health inequities. Another thing is that research and policy haven't really fully caught up with what Black communities have been saying for a very long time, that we don't see enough investment in Black-led research. There's gaps in that race disaggregated data and a lack of culturally grounded prevention and intervention. So we have to be able to name and address these systems that create unequal risks and access to care. I won't go into too much detail because we've gotten a nice introduction to these, but there are structural determinants, right? There are three levels: structural, psychosocial, and cultural community determinants when we're talking about mental health. The structural level, systemic racism, economic inequality, residential segregation, right? So all of these factors are playing an important role. People are seeing income gaps, job insecurity, unstable or even precarious work. All of these things accumulate into chronic stress that we feel in our bodies. And unequal access to getting the kind of help we need and the resources means that even when people have high needs, the care is often delayed or just not accessible. Psychosocial determinants, these are sort of the everyday experiences of interpersonal racism, microaggressions, racial trauma, the constant need to anticipate and manage or recover from racist encounters really creates an emotional and mental burden that often is invisible when we do our standard assessments. I know I do a lot of assessments, particularly with children. We don't capture these experiences very well, but they're very real in our lives. Cultural and community determinants, right? The beliefs and perceptions about mental health within Black communities often can influence how distress is expressed, whether people seek help, and from whom they seek help. So things like faith communities can be a source of resilience and support, but sometimes a barrier too, right? When mental health is sort of moralized or stigmatized in some way. And also how we perceive healthcare institutions. Often because fairly, there's a lot of history of neglect and harm in these institutions, so people don't trust it and they don't engage with the system. So that also further limits access to effective care. All of these things interact, and they combine to create a mental health, landscape that's fundamentally unequal. We do have data on these inequities and how they affect Black communities. Black communities and other racialized and Indigenous groups do show higher rates of depressive symptoms, anxiety, post-traumatic stress compared to the general population. This is important because at the same time that we face much more of these symptoms, we also have less access to care, longer delays when we're, before we get help, especially for a first-time mental health condition. So it's a critical point. There's high need, low access, and slow response. And that's an inequity not because of an individual, it's not someone's fault, but it's a system. We see underdiagnosis, over-medicalization, right? Especially among Black men and youth. Sometimes their symptoms are misinterpreted or minimized, right? Other times it's just a recommendation for medication without addressing those structural causes or providing appropriate supports. I've talked about low levels of trust of the system. And even at the high policy level, we don't have race disaggregated data, which is critical in terms of an issue, because we can't claim that we're evidence-based, but systematically we're under-collecting this kind of information, which makes it hard to make the claim and show where these disparities are, right? So these are some slides. Dr. Sinha and his team, wonderful studies that they've done, showing us that link, that racial trauma is trauma, and that's an understood concept, if I can say that. That these experiences of, everyday racism, being followed in stores, over-policed, underestimated when we're in schools or in workplaces, and these instances that might be dismissed as sort of minor and subjective, but when they're chronic and they're coupled with major events of discrimination, they can produce post-traumatic stress symptoms. And so these studies are showing that, that among Black populations, study after study, that everyday racism, as we experience more and more of that, so as that increases, we also see increased prevalence of PTSD symptoms, depressive symptoms, anxiety symptoms, and so this is really felt, okay? And it has profound implications for how we train clinicians, for how we design services, and how we invest in prevention, okay? Including anti-racist policies, right, that reduce that exposure to harm in the first place. We don't want to have to deal with this. But if we don't name racial trauma, as real trauma, like any other trauma, we'll continue to underestimate the burden of distress and the level of intervention that we need to help address this. Okay, so where do we go from here? We want to go beyond describing the issues to transforming them, right? So there's some key pathways to change. First, we want to really integrate the lived experience of Black communities into research and policy making. So meaningful partnership across the policy cycle, from setting the agenda to designing, implementation, and evaluation. Black communities can't just be consulted at the margins. We need to be really centered as people who have knowledge and hold that knowledge and can co-lead in this work. Second, we need to develop culturally grounded and community-based models of care, models that are anchored in Black communities' histories, cultures, realities, including for children and youth, which I think we'll talk about, another panel will address that. Supporting Black-led clinics, organizations, faith-based partners, right, who are already doing mental health work in different ways, but often not with the kind of funding they need to do it. We need to train our practitioners in cultural competence and cultural safety. We need to do better. We know that the mental health work landscape in terms of the professionals don't reflect the populations we serve, so we need to deal with that. It's a huge issue. But those that are out there doing this work, they need to do better. We need to train people. We also need to collect race-based data ethically and securely, right? In partnership with communities, transparently, with a transparency, it can really be a powerful tool for accountability. We can measure inequities, we can track progress, and ensure that policies are actually closing gaps. Almost done. And finally, we want to support research that is conducted by and for Black communities. So that includes funding Black scholars and community researchers, right? Researchers like myself, especially, emerging scholars, but established scholars. We need better pools. Community researchers who are doing great work, they're on the ground, You know, they know the realities, and if we arm them with the tools to further their work, we can really make gains. Community-based methods are important. And just recognizing that evidence and research can take a lot of different forms, right? So we want to acknowledge that. So just some questions as we move forward that I want you guys to think about. This is the last slide. But think about these questions. How can federal, provincial, and local governments embed anti-Black racism work as a core mental health strategy, not just as a side initiative? What are the specific investments that we need to build and sustain Black-led community-based mental health services across the life course? Pay attention, Black-led, community-based, okay. How will our institutions take responsibility for collecting, governing, and using race-based data in ways that are accountable to Black communities and explicitly tied to reducing inequities? Dr. Dryden talked about that. What does it look like for major health and research institutions, many of whom are represented, might be represented in this room? How do we share power with Black communities in setting these priorities and creating evidence? So let's think about that, and I hope that each of us in our respective roles are prepared to do things differently. Thank you.
What a wonderful way to start the morning, please. We are bringing well-renowned and emerging scholars at once. So I want to start with, first of all, really, this is for you. We don't want to talk at you, but I just want to ask one specific question to both of you that you mentioned in your talks and discussion. And it's something that probably a lot of us are very, very familiar with, which is the seeing racism as sickness. And what I'm getting at is there's something very peculiar and very particular about experiencing racism. It eats you up, right? So after you had the experience, like the police stopped me for absolutely no reason, and I'm quoting here, we're looking for a dark man with a dark bag. That's all the description he was going with. It eats you up because you keep thinking about it, and it consumes you in so many ways. And I think in many ways that is what you're trying to get at in terms of how we experience racism, how it traumatizes you, how it stays with you for so long. So I don't know if you have any comments, and then we open it up for the audience.
Sure. Okay. This is a really important question and observation, really, of the reality for many Black people, right? Is that we're overly surveilled, overly policed. I mean, there's so many ways. I talked about everyday racism, these sort of everyday things that happen, these situations that sometimes, especially when they're microaggressions, I don't really think they're micro, but it's hard to name and really understand what's going on, but it is felt in the body, right? When we talk about racial trauma, it's this accumulation of experiences like that, what you just described, where someone is profiled or wrongfully accused of something or whatever it might be, that for many of us who are Black has become sort of part of every day. You know, we're hyper-vigilant. We're aware of situations that we enter and possibilities of what could go wrong. So this is all felt in the body. And because it's repetitive, it doesn't end, it's relentless no matter where you are in the world. That chronic exposure changes our physiology, and you know about that. And it really just is a huge source of stress over time. So we see people coming in and it's manifesting, even though they might be experiencing anxiety or significant depression because of these experiences, sometimes it manifests in different ways. And so we do see people ending up in emergency rooms or in other circumstances where it becomes so dire. And the healthcare system isn't prepared to address that cause, that racism was happening, right?
It's, you need
Turn it
to
on.
put it on.
I thought I had. Okay, the little light went on. Is that not what's supposed to happen? Okay. Thank you very much. Sometimes these mics make me feel like I'm dealing with an Excel sheet. It just makes me sweaty. I do my graphs on a Word doc. I just can't with the calculations. I fully agree with this. And so Dr. Christina Sharp speaks about, and this is where I'm doing Black health studies, because I want to bring the scholarship to the research. We need to think about systemic anti-Black racism as the weather, right? It's the thing that always happens. There's always weather. Systemic anti-Black racism is always there. Another way to think of that is through critical race theory, which states very clearly that racism exists. It happens every day. And I just think of all the research dollars wasted going into community trying to measure if racism exists. And you can only think to ask that question if you're coming at it through a lens of white supremacy, right? This lens where it's like, no, everybody has a normal experience and racism is an aberration. But what Dr. Christina Sharp is talking about in her book, In the Wake, and what critical race theory is talking about is that it's not an aberration. As soon as you get up to put your pants on, there's racism happening. It is the structure that determined where you're living, where your groceries are, how you buy the car, how much more it costs. That it's the everyday, even how we understand illness. And so I also hear people talking about racism as a sickness, like racism is a disease that we need to correct. And I want to pull away from that because we can't medicate racism, right? The structural things that we need to do is more than a medication of racism, right? Yeah. But yes, it can cause illness. Yes. I think we should understand it as a comorbidity, as a thing that walks in with you into the clinical space. I think that's important because of all of these outcomes that are happening in our bodies because of the impacts of this structure on our very structural skeletal being, yes? So if we were looking at, for example, epigenetics, maybe then we could measure and map how trauma is actually changing our structures, genetic structure, through the transatlantic slave trade, which has impacted the entire globe, whether or not you're a recent arrival from a country that never had slavery or didn't participate. The transatlantic slavery has impacted the globe. So how does continuing racism, the transatlantic slave trade, inform the epigenetics of what is happening with our bodies? But that study is not happening. And just as a quick note, I want to say, anti-Black racism is understanding the racism that is anti-Black. Anti-racism is confronting racism. So we want to engage in anti-racism, but we don't want to engage in anti-Black racism, right? So anti-Black racism is the racism that's anti-Black, but anti-racism is the practices we engage in to disrupt the anti-Black racism. And I think sometimes the language gets murky for folks, but I think it's important for us to be able to clearly make those distinctions.
Absolutely, absolutely. I think your concerns around data is very significant. On peut recevoir les questions en français aussi s'il y a des questions. But I just wanted to emphasize especially I'm hoping that we have grad students in the room. We got plenty of research to do. That's for sure. So you've got so many lines of thinking and research and possibilities for actual grants, as we're going to see in the declaration later on. And I love your Dr. Dryden, your emphasis on the anti-Black racism as something that we need to be thinking about. And as I open it up for the audience, I wanted all of us to be thinking about what is it about race and Blackness in particular that gets people's spine up. As soon as we can talk about gender, we can talk about sexuality to some extent, we can talk about different things, but as soon as you bring racism and race, people feel uncomfortable. What is it about it that makes people uncomfortable? And this is just a rhetorical question. We got 3 mics, and I'm more than willing to actually walk around. If anybody has any questions, I will be more than happy. You can just get up with the mic. You can get up to the mic, or if you are if you want me, I can, or someone else will be able to bring the mic to you. Please.
Thank you. Hi, everyone.
If you can just present yourself, where you at, and then create a question.
I'm Somto Ibez. I'm a family doctor. I'm actually from Saskatoon.
Yeah.
I guess I'm here with sickle cell disease of Canada and with Black Physicians of Canada.
Nice.
Vice President.
Nice.
So my comment, thank you very much, Dr. Dryden and Dr. Iwenofu, for this fantastic presentation. And I've been thinking about anti-Black racism and how we deal with it. One of the things I always wondered is, it seems Black people, there's Black excellence. We all know that. And the Black excellence is such that our brains are not just limited to dealing with anti-racism and equity, diversity issues. We can do everything. But I often find that Black people are limited to areas of EDI or DEI, as if that's the only place where your brain is good enough for. And we all know that the power is in governance. That's where the power is, that's where the money is. And if we're not affecting policies from up there, it's as if the people in the governance room are telling you what to do. They determine where the money goes to. And oftentimes, the table is not made longer. And like Dr. Dryden said, most times you don't have to make it longer. You just need to move some certain people and put the right people that will do the work.
Right.
So I was wondering your thoughts on getting more Black people into proper positions of power, universities, federal, provincial, local government. In my thought, I think that's a way to go, but just wondering what your thoughts are.
Wonderful question. How about taking 2 or 3 questions and at once, and then we have about another 5 minutes or so. So please.
Good morning, bonjour. I am Sumendumbe Ayo. I'm an assistant professor at the University of Toronto at the Dalhousie School of Public Health and the executive director of the Black Health Education Collaborative, of which Dr. Dryden...
The center of the universe.
Yes, it is, isn't it? Of which I'm the executive director of the Black Health Education Collaborative, and Dr. Dryden is one of our co-founders. I want to pick up on... Yes, we're great, aren't we? I want to pick up on that question 2, around specific investments for Black-led community mental health services. We're in Ottawa today, and we're going to be signing the Ottawa Declaration, which has some asks, I would say, around investments in Black health across the board. So how do you make sense of that declaration? And I think the Minister of Health is going to be there for that, right?
She will be signing.
Exactly. How do you make sense of that alongside the fact that right now, the federal government is planning to end the only investment in Black health which it has, which is $18 million, which has been invested since 2018. That program is set to end next year in March. So how do you make sense of this contradiction that we're proclaiming on one hand and simultaneously ending the current investments which exist, which are not anywhere sufficient to meet the needs?
Yeah, a wonderful question. Yeah, you can jump in. Whichever questions you want to address.
Okay. Thank you for those really thought-provoking questions. I think in terms of the first one, which I appreciate, around getting, Black people in positions of power, I echo that sentiment. I think that is a critical part of what we need. We're not in enough of the spaces that we need to be. And sometimes, even when we take the effort to create new spaces, perhaps where we can have the opportunity to take a lead role, there are often forces at play that sort of divide and get at that unity or that collective effort that we really have to resist. We're always resisting in some way, and it's tiring. I will say, as you know, and I see this a lot, you know, as the chair of our Black psychology section within the Canadian National Psychological Association. There's you see it, the subtle ways in which, you know, even those of us who try to enter those spaces where we can have some more power, there are subtle ways where that is that power is attacked or minimized, or we're sort of relegated to the margins. And so my view on it is that you have to keep pushing. Every one of us have different power, sort of realms of influence, right, in terms of what we do. And I think that power begins within. So you have to, first of all, know and own it, that you can have the capacity to affect change in whatever you're doing. Don't let anyone else bestow power on you or tell you that, you know, you have to first believe that you have it inside, okay? I hold that because it gets tough. It gets tough. And so I have to remind myself of the power that I do know I have, given to me by God, given to me by my ancestors, my family. So that gives me the confidence to go out. In my role as a faculty member, as a professor, my hope is that maybe not in my generation, but hopefully as generations come up, we can continue to open those doors. So I open the doors, right, to psychology, clinical psychology education and graduate training to Black students that are coming through. Because we need Black faculty. We don't have enough Black faculty in these institutions. And so when one or two of us are let in, let's open those doors, right, for others. Because that's how we continue to increase the pool and the potential to occupy power in certain spaces. I could go on and on about it, but I think, again, it starts with within. Hold inside of you that you have the capacity. And then, you know, hold that door open for somebody that's coming through as well. And the second question I will leave for now.
Yeah,
Perfect. I want us to think really strategically about what our purpose is at these tables and why we want to be at these tables, right? Because we see that there are Black people who are at these decision-making tables who have been used to our detriment, right? So we've seen the Black academic or the Black provost or the Black senior admin who's been the person that's closed Black studies, who's been the person that's canceled cohort hiring, yeah? Because you get at the tables and the work is to do that work of structural white supremacy, yeah? So I'm not sure if our entire focus should always be at that table. But if you are going to be at the table, don't assume that you already have the history of how these systems work to sit and do the work you need to do at the table. Go to the scholarship, not the blog post, not the, you know, not the Lancet article. Go to the scholarship. Do the reading, right? When the Black Panther parties began and before they opened community clinics, they did the reading to better understand how to have effective community health centers in Black communities. They did that work before they went out to do interventions. And I think people get to these tables and they think at the table, oh, now I'm just going to be treated like everyone else, and not fully understand how systemic white supremacy works in that place, and that the expectation is for you to also parrot that harm. And then some folks are like, but I need to stay at this table, and allow themselves to be compromised in those ways. And we need to speak very plainly that that happens. Simultaneously, while you're at the table, make sure you're working with people who are not at the table, that you're strategizing with, and that you're empowering, because there's work we can do that's not necessarily at that table. Right? And so it has to be a multi-pronged process. It can't simply just be at the table. Dionne Brand wrote an article in July 2020 in the Toronto Star, where she talks about palliation. We think of palliative care. Is the only purpose to get at the table and then we're good? We're not actually looking at the underlying course? Or is the purpose to actually get there and be the thorn in the side to disrupt that underlying course? And I would argue it's to be the thorn in the side. And because I've been that, I've often been uninvited from tables. And that's okay. Because the purpose is to try and cleave things open to have something else happen. You have to do something different for a different outcome. So how are you preparing yourself to do that different thing? In terms of funding, and I'll be quick here, I've been working with a group of Black researchers agitating with PHAC and CIHR, or FAC, whatever you call them. Why is it that you have a funding stream, you understand maybe that colonization includes slavery, but you don't have specific Black funding? But then you have one funding pocket of money, and it's only going to go to one research team, as if all Black people are the same. What are you doing? Or why is it, if you want to do research on Black, queer, and trans people, you go to the white researcher who's never done anything for Black, queer, and trans people and say they're gay, add Black to that? That's not how that works, right? And how are we surveilling each other to also be like, well, I don't want to do that work with Black, queer, and trans people? Stop it. Engaging in that kind of homophobia and transphobia is a practice of white supremacy. Let's not repeat that, yeah? Let's not engage in that. So then what conversation, I agree with Sume here, what conversation are we having with the feds, with Health Canada, that says, yes, you might have a data governance protocol with Indigenous people in the various treaties, but where's the data governance protocol for Black people if you are committed to a decolonizing process?
Yes.
Where's that?
Yes.
You may have funding streams for Indigenous people, as you should, but where are the multiple funding streams that talk about Black African Nova Scotians, Black folks in the prairies, Black folks on the West, Black newcomers, Black queer folks, Black elder? Are we all supposed to do that with the $1 million that you told us to do in 2 years? Are you kidding? How are we supposed to do that? And then you say to us, well, we're being told to cut 20%. So it's not my fault, there's nothing I can do, so I'm gonna take it out of your pocket? That's anti-Black. So how are we willing to have that conversation? I'm glad they're signing this, but it also needs to come with a funding envelope for the Black peoples, plural, across the country, and the Black diversity, newcomers, queers, youth, elders, Black folks with disabilities, so we can actually collect the data that we require. So those are my 3 answers. Thank you.
You got that right, girl. All right. So the idea is not to reach all answers all at once, and we are running 15 minutes behind time. So I'm student. Oh, absolutely. You want to ask? You can answer. You can ask the question, and then we will just leave it for the audience for the session.
Thank you so much for the opportunity. My name is Joachim Tamale, and I am an LLM candidate at the University of Ottawa Centre for Health Law Policy and Ethics. And I am here to represent the Black Law Students Association. My area of research is law as a determinant of health among immigrants and refugees in Canada. And throughout my research, what has come out a lot is how we experience structural and systematic racism and discrimination as a result of racist laws and policies. I want to be blunt about that, racist laws and policies. And I want to single out Bill C2. I'm glad it's now Bill 12, but certain components of it really looked at newcomers or immigrants, who a larger number of which are Blacks, as threats to national security, as people causing economic challenges, as people threatening the security of Canadians. So one of the things that I wanted to mention about our laws, policies, and procedures that actually elevate or escalate the vulnerability of Black people, especially Black newcomers. Thank you so much.
No, thank you. Thank you. Thank you so much. Let me assure you that we have beautiful, beautiful volunteers of note takers, my apologies. It's in the morning. I need coffee. And they, if you have any, whatever questions you have asked, they have taken note of it, and it will be part of the ultimate report that we will come out of the roundtable. So, 2 minutes. We didn't want 2 minutes. We just want to say, can we just give a huge round of applause to these beautiful, beautiful scholars. One thing that you do not know about Dr. Dryden is she's also a poet. And you could see it in her dressing, girl. Like she's on fire. All right. Okay. So one absolute last comment, and it will be 1 minute.
Okay.
Senna said 2 minutes. I'm going to give you 1 minute.
Okay.
Compromise.
Okay. So hi everyone. My name is Stevens Azima. I'm from Quebec originally, but I'm currently a postdoctoral researcher at the University of Vermont. So I come from the U.S.
There you go.
And I'm an agricultural economist, so I'm interested in food, agriculture, and food insecurity. And I was glad that one of you brought the issue of food deserts. And food insecurity is also mentioned in the Ottawa Declaration, and I think that's a good point, because we have solid research showing that food insecurity is a key determinant of health, but also adverse health conditions and poor health ecosystems can also affect food insecurity, which creates a negative feedback loop. And when we know that most children facing food insecurity are living among Black households in Canada, this is concerning because I'm from Haiti, and we have something that says the children today are the adults tomorrow. Like,
Indeed.
Well, my question is, how do we make sense of all of this, given how slow the Canadian government has been in creating a universal school program for children?
Okay.
Thank you.
We have a lot of questions to the minister when she's here. I'm just kidding. Okay, thank you all so very much. I think we can move to the bridge panel next.